Hi everybody, good evening. I'm Dr. Carrie Riestenberg. I'm coming to you from Coastal Fertility Specialists, and tonight in celebration of Pride Month, we're going to be talking about LGBTQ family building options. So I'm just going to dive right in, but feel free to enter any questions that you may have into the chat and we will field those as they come in. So first of all, I just wanted to say this is one of my favorite patient populations that we love to take care of at Coastal Fertility here. I'm going to talk to you about some of the basics today, but I'll also always know that you are welcome to schedule a consultation. No referral is required, so you can always come in for us to discuss your options for yourself and or your partner in more detail. So we're going to start off tonight talking about family building options for same-sex couples, and we're going to start with same-sex female couples. So generally when a couple will come in, we start with just a general history and physical exam, and then a conversation of what the desired family building goals are. And this is really what will guide the options in terms of further testing and treatment. So for same-sex female couples, the conversation will generally begin with, if there is already a decision as to who desires to carry the pregnancy, if any thought has been put into what the sperm source will be, and what each partner's involvement, what each partner desires for their involvement in the pregnancy. So generally we do start with regular testing for fertility for each partner that wants to be involved in the process, and that's the same kind of testing that we do for all of our patients. So start by getting a thorough history, a physical exam, a pelvic ultrasound, which we'll do during your first consultation in the office, which will give us good visualization of the uterus and the ovaries. That gives us an idea about your egg quantity. And then I do also recommend standard ovarian reserve testing, which is blood testing that we do typically on the third day of your menstrual cycle to give us more information about your egg quantity. I do typically also recommend a hysterosalpingogram, which is an X-ray dye test that looks at the inside shape of the uterus and at the fallopian tubes to make sure that they're open before we move forward with either kind of treatment, which we'll discuss in more detail next, but would include either insemination or IVF. So after we've kind of established who desires to carry the pregnancy, then we talk about different options for conceiving. So number one, and the most simple or straightforward treatment option would be donor sperm insemination. So that would be a situation where one partner desired to be both the source of the egg and desired to carry the pregnancy. If that person does not have any history of infertility, then what I do generally recommend, and this does depend on your medical history and age and a few other factors, but generally I'll recommend starting with what's called natural cycle intrauterine insemination. And what that means is that for women with a regular menstrual cycle every 21 to 35 days, that we would teach you how to test for ovulation at home. We'll tell you what ovulation predictor kits to buy. These are urine test strips, which can be bought typically on Amazon or at Target or anywhere really, CVS. And we'll tell you what day during your menstrual cycle to start testing your urine for ovulation. You test once a day, typically in the morning. And when you get that positive, then you would call your nurse, and the following day, the insemination would occur. So it basically eliminates any unnecessary testing, it keeps the cost low, and really gives you a good chance of pregnancy each month. So the natural fertility rate is about 15 to 20%, and that's what I would expect for most patients. So that's kind of a brief overview of natural cycle insemination. In order to move forward with that, some of the other things that we need to do are identify the sperm source. So we have two main options, either sperm from a sperm bank or sperm from a known sperm donor. For the sperm bank options, I will typically give my patients three of the names of some of the top sperm banks that I like to use, and that would be California Cryobank, Seattle Sperm Bank, or Fairfax Sperm Bank. I'm open to any sperm bank that my patients want to use, but those are three that have a really long-standing good reputation and that we tend to get good sperm samples from. So I provide kind of that information. And then I do generally recommend that my patients do what's called genetic carrier screening before selecting the sperm donor. So what that is it's a blood test that I generally recommend for anyone who thinks that we're going to be using their egg moving forward. So either for baby number one, whoever is going to be doing the insemination, or let's say both partners eventually want to carry a pregnancy, then I recommend it for both partners. It's a blood test that tests for about 60 different genetic mutations that you could be a carrier of. These are single gene mutations that result in disease, things like cystic fibrosis, spinal muscular atrophy, muscular dystrophy, thalassemia, sickle cell, etc. And so if either partner tests positive for any of these mutations, I recommend selecting a sperm donor who does not have the same exact mutation. Because if you do have the same exact mutation, there's a 25% chance that the child could be affected by the disease. So really between that and your personal preferences, between kind of the sperm donor background, medical history, family history, interests, etc., those are the criteria that I recommend selecting the sperm donor based on. So we talked a little bit about natural cycle insemination. The other option, which we sometimes progress to if we're not successful with the initial natural cycle insemination or several cycles of that, would be a medicated insemination cycle. So what's involved in that is a little bit more monitoring, where you would call with the first day of your menstrual cycle. We'd bring you in for an ultrasound to make sure the ovaries are at baseline, and then we would start medication to stimulate the ovaries and kind of to achieve a hyperstimulation and hopefully get more than one egg to ovulate. Then we similarly would follow you with a couple of ultrasounds to monitor for the ovarian response. Sometimes we use a trigger injection to force ovulation, and then we time the insemination based on that. So the reason that we don't start typically with a medicated insemination cycle for couples who don't have any history of infertility is that in same-sex female couples doing inseminations with donor sperm, it hasn't been shown to increase pregnancy rates, but just increases rates of multiple gestation. So this has been compared in studies, and it really doesn't help us achieve the goal, which is really a singleton pregnancy, because that's the healthiest and safest thing for mom and baby. But is something we consider based upon other factors, and if there have been several cycles of unsuccessful natural cycle insemination. So that kind of caps off our conversation about insemination. The other option is IVF. So either in a couple who has been unsuccessful with intrauterine inseminations, or in a couple who desires what we call reciprocal IVF or co-IVF. Those are two circumstances where we would consider IVF. So IVF is a more advanced fertility treatment that involves stimulating the ovaries of whoever wants to contribute the egg for the pregnancy. We give you high doses of gonadotropin injection medications. Those are the same hormones that your brain makes naturally to control the ovaries. We just give them to you at higher doses, so that instead of only growing one follicle and releasing one egg in the month, we want to recruit and grow as many as possible. The eggs are extracted from the body through a transvaginal procedure, which is done under anesthesia. And then those eggs are fertilized with the sperm in the lab. Those fertilized eggs are then grown typically for several days in the lab until they reach an embryo stage. And then either partner can be prepared, have their uterus prepared, and the embryo can then be transferred. So this is kind of a neat option where both people can be involved in the pregnancy. One person can be the contributor of the egg, and then the other partner can carry the pregnancy. So that's when it's called reciprocal or co-IVF. So I think that basically covers options for same-sex female couples. I wanted to just check in to see if there are any questions at this time. Not yet? Okay. Okay, so those are, that's for same-sex female couples. So we're going to go ahead and move on to same-sex male couples. So for same-sex male couples, this is a little different. In same-sex female couples, we had to identify what the sperm source was. In same-sex male couples, we're talking about the egg source and then the carrier of the pregnancy. So when I first had my conversation with my same-sex male couples, we talked generally about different places where we might obtain the eggs. One is typically from a frozen egg bank. We at Coastal Fertility are a participating center of Donor Egg Bank USA, and that is basically a constellation of clinics across the United States who do participate in egg freezing for the donor egg bank. So that is one option. From the donor egg bank, eggs are typically purchased in lots of 6 to 8 eggs, and those are previously frozen by women across the United States. So some of the benefits of donor egg bank include a wider variety of kind of patient backgrounds. It tends to be less expensive because you're purchasing a smaller lot of eggs typically. And sometimes this option can be a little bit faster because the eggs are already frozen, and once they're purchased, they are basically shipped to your clinic or to Coastal Fertility, and then we move forward with treatment. The other primary option for egg source would be through a fresh egg donor program like what we have at Coastal Fertility. So we at Coastal Fertility have a fresh egg donor program in which we've hand-selected women from North Carolina, South Carolina, and Georgia who meet high standards for egg quantity and kind of medical background, and those women have opted to be fresh egg donors, where you would have the opportunity to review their profile and then select someone who would then go through a fresh stimulation. And then you have the option to purchase either half or all of the eggs that are retrieved in an egg cycle, in an egg stimulation cycle. So some of the benefits of the fresh egg donor program are that you typically get a higher quantity of eggs, and the success rates are slightly higher because the eggs are not previously frozen, and all of the stimulation and management of the embryology is done at Coastal Fertility in our lab, we do have a very good lab. So that's option number 2 for egg source. Option number 3 would be a known egg donor. So if you have a family member or friend who is offered to be an egg donor for you, we would basically want to bring her in for an evaluation, do a physical exam, laboratory testing, and pelvic ultrasound so that we could evaluate if she would be a good candidate for egg donation for you. And that's how we would start there. So once the egg source has been identified, we need to identify the sperm source. So oftentimes for same-sex male couples, one partner may use their sperm for a first pregnancy, and then perhaps for a future pregnancy we use the partner's sperm. If that is the plan, we will often actually create embryos using both partners' sperm at the same time, so that those are created up front. And then one embryo may be transferred first, and then another one in the future. So we would have a conversation and again review each partner's medical history, see if there are any medical indications why one partner would prefer to use their sperm over another, but oftentimes it's largely a couple's preference. So finally, the final component is the carrier. So this has been traditionally called surrogacy and is often called surrogacy even today. Surrogacy isn't quite exactly the right word for it, so what we really call it is a gestational carrier. So a gestational carrier is often a person who is either found through a gestational carrier agency or again can be a known gestational carrier. I'd say the majority of our couples do use gestational carriers that are identified through gestational carrier agencies. So if that is the option that you're choosing, our nurse, who would be your specialized nurse, would put you in touch with different agencies that we've worked with historically, and then the agency would provide different candidates for you to be your gestational carrier. Once someone has been identified as a potential gestational carrier, your physician does a thorough review of that person's medical history, obstetric history, etc., to make sure that they are a good candidate to be a gestational carrier, to make sure that it would be a safe thing for that person to embark on for their own health, and that they would give a good chance to carry a healthy pregnancy for you. So that's identifying the gestational carrier through an agency. And then similarly, if you had someone who had offered to be a gestational carrier for you, we would again bring them in, do a full history and physical exam, take an obstetric history, and make sure that they would be a good candidate to carry a healthy pregnancy. So those are the main options there. I think that pretty much covers it. If we don't have any questions about that.
I have one comment here.
Okay.
Kevin says, we found ourselves overwhelmed with financial aspects, organizing everything for the processes. Can you review option types of financial avenues for same-sex male couples? We're under the impression the first step, egg donor selection process, financial due is up front prior to starting the process. What would you recommend for handling logistics like these?
Okay, so great question, and it is absolutely true, Kevin, that financial stress is one of the main reasons that patients drop out of treatment, and it breaks my heart, and we hate that. I have to say this is not an area of my own personal expertise, but I will say that at Coastal Fertility, you'll have a team taking care of you. So you'll have your doctor, okay, and I actually know that there are resources for same-sex male couples. I was just at an outstanding lecture by Dr. Mark Leondaris at our donor egg bank meeting earlier this year, and I'm looking in his PowerPoint, and we can post on this.
Yeah.
We can post on this video after the fact, but I know that he gave me some really great resources for financial support, specifically for same-sex male couples, because obviously it's a huge financial burden, the cost of the gestational carrier and the egg donors. So I completely hear you. Let me update you with that post after we conclude the video, okay? But I do know that there are resources out there for support, and in addition, you'll have your physician, your nurse who specializes in taking care of patients who use, egg donation and gestational carriers, and then you will be given a specific financial counselor once you have your initial consultation. So at your very first meeting with us, you'll meet with your doctor, you'll meet with your nurse, and then you'll meet with your financial counselor so that they can give you all the information about the different options, the financial implications of each option. And as we discussed, the egg bank is different from the fresh egg donation. And then known gestational carriers are different from carriers found through agencies. We do have different kind of financing option information that the financial counselors will also go over with you. And then again, I promise to post the update about, I know that I have some support here for same-sex male couples. So we're here for you, and I will post those resources after we conclude the live feed. Thank you for your question.
So Sam asked, can you include some resources for support for same-sex female couples as well, both IUI and IVF?
Yes, absolutely. I know that I have those as well, and we will post those afterwards. So there are certainly kind of financing options that are available to everyone. There are options for patients with, there are kind of infertility grants and kind of funds that are available for you to apply for, and then there are specific funds for both same-sex male and same-sex female patients. So we will post those afterwards. Absolutely. Thanks for your question, Sam.
Okay. I don't know if there's anybody else. I think those were the two main questions.
Okay. Yeah. So we will absolutely update this post with those resources afterwards. Thank you guys for those questions. So I think to cap off the conversation, I just wanted to close with some options for transgender patients. So for our transgender patients, it's very important that people be aware that there are options both before, during, and after gender affirming therapy. So I think there's a lot of misconceptions that once a patient begins gender affirming therapy, that options for fertility preservation or fertility are not really available. And I want you to know that that's not the case. That's more of a outdated and old-fashioned way of thinking about it. So for these patients, the conversation really has to be tailored to their personal situation. But I will say that in general, for transgender male patients, first we have to talk about, have you transitioned? And if not, and are planning to, often we will be having a conversation about egg freezing so that we can preserve your option for having biologic children down the line with those eggs. And the options for that can be variable depending on if you have a partner and who your partner is. So, but there are certainly options for egg freezing. If you have already initiated gender affirming therapy, then we have two options available. One is to stop gender affirming therapy for long enough that you would become ovulatory. And then we have options of either insemination or IVF, okay? Or also potentially intercourse, depending on your partner. The other option is to just pause gender affirming hormonal therapy and then to try to stimulate the ovaries. So that generally requires a shorter duration of being off the gender affirming hormonal therapy. Success rates with each of these treatment options are really dependent on your personal situation. So kind of your age, egg quantity, how long you've been on the therapy, and our goals. So I really encourage you, make an appointment, come on in. We're here to talk about these options, okay? But I just want you to know that there are options available. And then finally, for transgender female patients. So again, first we have a conversation about, have you transitioned? If not, we're going to be talking about freezing sperm. Okay, so that you have the option to then transition and then use that sperm in the future. If gender affirming hormonal therapy has been begun, again, it's a similar kind of conversation. First, we have to see, is there sperm present? And if so, we can consider options of insemination or IVF, depending on your partner and desire for family building at the time. If there is not sperm present, then we have a conversation of either pausing or temporarily stopping the gender-affirming hormonal therapy to see if we can get sperm recovery, which we oftentimes can. This is sometimes done in conjunction with a male reproductive urology specialist who can help us with a sperm recovery protocol to kind of kickstart the sperm production again, depending on how long you've been on the hormonal therapy. So I know that's a very brief overview. I think that, my takeaway here is that everyone can have a different plan. There are lots of different options available, and we're here to talk about a plan tailored to you and your family building goals. So please come in and see us.
Got one more question.
Okay, yes.
Okay, Kevin's back and he wants to know, can you break down the steps in which we'd have to go through roughly, as like the need to obtain FDA physical, FDA psych eval, etc.?
Yeah, so I can tell you that in general, there aren't necessarily like step 1, 2, 3, 4. There is kind of a list of things that we need to accomplish. So you're right that FDA hormonal testing, FDA blood testing has to be done. An FDA physical exam has to be done. We do have a requirement to have a lawyer involved to get legal documentation to protect you and your partner, and to have a conversation about how to protect your parental rights. So, we want to know, are you married? Will both names be on the birth certificate? Is it recommended that the partner who is not contributing the gametes, the sperm, adopt the child in the future? So this is a really detailed conversation with a lawyer, and we have a great lawyer who works with a lot of our patients. So we would refer you to that lawyer. And then there's a psychological evaluation that we also recommend, and really is largely to give you tools for talking to your children about this in the future. So I'd say those are the main steps that are involved, in addition to identifying the egg source and then who will be the carrier. I encourage you to just schedule a consultation and we can go over that in more detail. But thank you for your question.
Okay, great. I think that's it.
Okay, wonderful. Well, again, happy Pride Month. It's been nice spending a little bit of my evening with you guys. Please come on in. We'd love to chat. And take care. We hope to see you soon. Bye.